And then I'm gonna. Okay. Okay. So, good evening, everyone. At this time, I want to welcome everyone for taking the time to attend this online discussion. I have placed everyone on mute at this time to prevent any background noise. Welcome, thank you for making the time for this discussion today to address racism and health. Before we begin, we will start with the introductions of our panelists. Okay. So my name is Mabel Kimball. I am currently a medical student, first-year medical student at AUC School of Medicine. And my background is that I received my MPH in social epi and master's in biomedical sciences. I used to work as a research scientist at UCLA, where I did a lot of my research work in terms of infectious diseases, HIV, hepatitis C was majority of the work that I did. Go ahead, Atala.
Hi, everyone. My name is Atala Dillard. I'm a fourth-year doctoral student at UCLA with the School of Nursing. My background, undergrad, was in public health. I then transitioned into a more clinical role as a registered nurse. I currently practice as a neurosurgical nurse at Cedars-Sinai, as well as my work at UCLA is currently looking at racial identity and its effects on PrEP adherence among Black MSM, as well as looking at trauma, specifically racial trauma and childhood sexual abuse and its influence on the lack of PrEP adherence among Black MSM.
Go ahead, Jamie.
Everyone, my name is Jamie Murphy. I am a third-year PhD candidate at NYU. I'm in the School of Public Health, and my concentration is in epidemiology. My background is kind of all over the place, but still related. So I started nutrition in undergrad, and then I got an MPH in health policy. And now I've done research in both clinical behavioral settings, looking at infectious diseases and chronic diseases. My work right now kind of centers around looking at social and structural influences on adverse health outcomes among people of color. So really, while in my program right now, I'm specifically focusing on racism and cardiovascular disease outcomes amongst Blacks. So.
Cool. So we received an amazing response for this webinar, and your active participation is very important to us throughout the conversation. So we encourage you to use the Zoom chat that you see on your end, if you can. We encourage you to access that and share your questions and comments during the webinar. We are going to use the chat box to functionality to answer the questions you have added during the question and answer period of the discussion we're going to have today. So as you know, today we're having this very difficult discussion, conversation, one that we believe as a collective is necessary. So we're going to be able to explore how racism affects the health and well-being of those who are considered underserved. So this slide just outlines what we'll talk about throughout the webinar, the agenda, and we already did the introduction. And this slide just talks about some of the terms used when we have conversations, just the one we're having now. In public health, this is pretty much like a language that allows you to have a deeper conversation with your public health counterparts or medical professionals or civilians. So we'll define some terms during this talk. However, these are terms that you want to review outside of this presentation, just so you are aware of how they're used in the public health world. So race is as defined as a social construct created to divide people in order to prevent the majority of people from rising up against those with wealth and power. Then racism is a system of structuring opportunity and assigning value based on phenotype, what someone looks like, their skin color, unfair, and because of that, there's unfairly disadvantages for some individuals and community in terms of that actual subgroup. People of color is kind of like the term that you most likely hear, and it's used from the Americas and Africa and Asia and Arab world and Asian Pacific Island Americans. So people of color have chosen this term as an identity that unifies different racial backgrounds. Health, and according to the WHO, it's just defined as a state of physical, mental, and social well-being, not merely absence of disease. Health disparity is just the differences among specific subgroups in the United States, differences in health, differences in income, differences in whatever it is that creates a burden of disease and adverse health conditions. Health equity is a state in which everyone has an opportunity to attain full health potential and no one is disadvantaged. And this is pretty much what we'll talk about a little bit today in the health, with the goal with the Healthy People 2020, when they said that they wanted to eliminate health disparities that exist in the United States. And we'll talk more about the historical background that will suggest to you that these issues that we're going to be talking about today have existed for a very long time. So before we started like the meat of the conversation, we wanted to start with Dr. Martin Luther King and Jr. and a quote that we believe is really important. And it just says, of all forms of inequality, injustice in health and care is the most shocking and inhumane. And so we're going to begin with the objective and discuss the approach we will take today, but we hope that at the end of this session, you would be able to explain what racism is and why it is so challenging to make progress in our public health goals. And we hope that really that you would be able to gain the ability to desensitize the term in order to be able to address it in your everyday activities. And a couple of days ago, you know, a colleague of mine asked me the other day why I'm using the word racism for this for the webinar, and I said to them, you know, well, if you listen to the webinar, maybe you'll understand why we had to use the word racism as part of the effort to educate and spread knowledge about why this specific topic is really important. So we're going to start with a brief background on the current status of racism in health in the United States by using Black Americans as an example. And then Jamie will discuss some stories that will allow you to have a deeper understanding of the issues and enable conversations in the communities that you represent, or as a public health practitioner, as a medical student, that will help you become more competent in understanding this specific issue. So this slide just pretty much tells you that the discussion about race, health, and equality really has been around for a long time. So we have known for some time that inequality related to race exists. But for practical purposes, we usually use the 1985 Heckler Report which was established by Secretary Margaret Heckler under the presidency of Reagan, which really highlighted the major causes of differences in death between minority populations and the general population. So as you can see, this was a thorough report. It's pretty thick, and it has an executive summary. It has 8 volumes, and it pretty much addresses the causes of death and the health problems that plague the community of color. But first, before we go over all the background, the main theme of that specific report was just excess death. We need to be able to define what that means. So the major theme of this report is just there were too much death in the Black and minority, or just in the minority communities, period. And this is defined as the differences in numbers of death observed in the minority population and the number that would be expected if that minority population had the same age-specific rates as the non-minority population, which was basically, what usually is used as a reference when you're talking about public health and African Americans. As a reference point are the general population or the white population. So now, life expectancy is a metric that is used to evaluate health status. And if you look at this graph outlining life expectancy dating from 2006 to 2017, male in general has lower life expectancy versus females. So this is usually a common finding on research. And if you look closely as well, you'll see that that Black male have the lowest life expectancy compared to white males, and Black females are lower than white females. So a lot of different factors contribute to life expectancy, and as you can see, there is a lot of room for improvement, especially if the life expectancy of the population in general is optimal across the globe. But as African Americans, we don't have the best life expectancy across the globe. So there's room for improvement due to the factors that contribute to life expectancy of my communities of color. And this slide just pretty much talks about early life, and one of the factors reported in the Heckler report is low birth weight, which is listed as a risk factor for infant mortality. And these data it looks like, as you can see, the 2 lines are narrowing, and there's, you see the gap when you look at infant mortality, when you look at it, and the red line pretty much represent the non-Hispanic Black population. And this shows that the low birth weight and infant mortality is more than twice as high as in Black compared to the Hispanic white. And this has been, and if you look at it, it's been persistent for a very long time. And this is one of the things that we had to look at, because when we look at where we are after the Heckler report, we are still, we still have a very long way to go in terms of, infant mortality specifically. And in adulthood, this one is a metric that we use called years of life lost before 75, or sometimes people call it as a premature mortality for several major causes of death, including the ones that were used in the Heckler report. So this metric is good because not only does it pick up the death rate in a particular group, but it also picks up the death. So if you die younger, the more years of life is pretty much lost. So if you look at the top two lines in both groups for heart disease and cancer, contributing to the largest numbers of years life lost, and if you compared that, they are going down, but they're still higher for Blacks than they are for whites, especially for heart disease. But obviously, it has gone down more in whites than in Black. And in addition, the other striking thing about these graphs is that the other three conditions we see up there is also high in Blacks, and homicide is among those, which looks like we still have a long way to go. And even though, as I say, all these are going down, on another hand, you can see that we are improving, or that we are able to improve, but we are not improving at an efficiency, at an accelerated rate in order to close the gap. So pretty much like the slides that I've been showing you are just, sort of just a minimum of what disparities look like. And it shows you the trends to indicate that we have not closed the gap, that these data, many of you have probably seen these information over and over again, and it gives you the sense that there is an intractable issue that seems to be almost intrinsic to a population. We don't want to dwell on these data, but I want to briefly talk about the government and had down to try to address and offer intervention to close the gaps we still see even after the Heckler report. So the Healthy People 2020 really put the issues of determinants on the map and said that in addition to the individual behavior, health care, we had to get to some kind of root causes, and this is the way that social determinants are described on the Healthy 2020. These are the quotes on the website that you see on the slide. So there's some leading indicators that are used to track how well we're doing on social determinants. So as you can see at the bottom, a key social determinant of health is education. So there are some leading health indicators that are used to track, like I said earlier. And if you look at this one, and usually the target that the Healthy People 2020 set is for education to be reached at 85%. And you can see that, outside from the white American and Asian Hispanic population, Hispanic, Black, and American Indian and Alaska Native haven't reached that goal. And this slide shows the poverty based on race over time. So as you can see, the yellow line just tells you the total poverty rate of the United States. And then if you look at the poverty rate for African Americans versus Hispanic, you can see that African Americans still has the highest rates. So coming back to the overview that we talked about earlier, now that you had some background and some ideas about the disparities that we've discussed and why we think this is important, now I'm going to turn this over to Jamie, and he's going to talk to you more about, or pretty much just help you really understand this more deeply and enable you to have conversation about it on behalf of public health. Go ahead, Jamie.
So next slide. So when we talk about racism, I think usually people think about some type of prejudice or discrimination that you have based on a social construct, which is basically our race. But there are also two other levels of racism. And this is I'm kind of linking this to a story called The Gardener's Tale, which was proposed by a former American Public Health Association president named Kamara Jones. So the first level is this institutionalized racism, which you can think kind of in the name of being an institution and how racism is kind of perpetuated within that system. So examples of institutions would be things like education systems. We think of government, we think of hospitals, different things like that. And the way how racism can be, I guess, expressed in that way would be differential access to those goods and services. Even the quality, to go so far as thinking about education, for example, is something that is considered a right in the United States. But if you think about maybe where you grew up, or you just think about the layout of your city, there are various degrees in terms of the quality of the education that's received depending on where you go to school. And the same is kind of when we think about hospital or kind of access to hospitals. So that's at the institutional level. Then there's just something called this personally mediated racism, which is kind of what I was describing at the very beginning. Was this what we normally think of as racism, kind of this prejudice that someone has on the basis of someone else's race or skin tone. This social construct of race, which isn't biologically plausible. Then we have this third level called internalized racism, and this is actually when the stereotypes and the prejudices that you might receive based on your race, you start to internalize that and think of yourself as being less than. So you kind of want to receive the same benefits from maybe the majority group when we're talking about race in this sense. So you try to change things and try to think about more like assimilation or thinking that that you're not good enough in that way. And so kind of bringing it back, Kamara Jones, she kind of proposed this really, I think it's an easy way, Gardener's Tale. And so basically we can think about this as, just say a person just went and buy a new home. And they wanted to get into gardening. There's some empty potters outside. They noticed that, about half of the pots have soil already in it, probably left over from the previous homeowners. But the other half were empty. So they decided to go to the store, get some soil. This is fresh soil, it's rich, has all the nutrients that kind of help, whatever's planted in it grow and kind of thrive. And so this gardener, a budding gardener, decides to pick out two different colors of flowers. Red is their favorite color, so they pick red flowers, and they need another one, so they pick pink. And they decide to pot these different flowers, the reds in one pot, and decide to plant the pink ones in the other pot. And because red's their favorite color, they decide to actually put the red flowers into the new soil that they just bought and just kind of, put the pink flowers in the soil that was left over from the previous homeowners. So they're watering these plants, over the weeks, maybe 3 weeks pass by, and they notice that the red flowers are thriving. They're doing great. They're looking alive. They're taking over the pot. But the pink flowers are kind of just barely making it, barely sprouting, kind of dying and looking kind of frail. And these are the type of flowers that, regrow every year. They notice every year that, these red flowers are getting bigger and bigger. And, the pink flowers, after 5 years, maybe they're just as good as the first year with the red flowers. And to the fact that actually the gardener starts to think like, okay, I made a good decision to actually putting the red flowers in kind of this new soil because these did better compared to the pink flowers. And so I'll show you how this kind of relates to racism and these three levels that we just kind of talking about. And so thinking about the institutionalized racism, you could think about these pots as being institutions. So access to quality of goods and services. Because this gardener, I prefer red over pink, I decided to give the red flowers, top of the line quality, soil so it can grow. And I just kind of got this leftover soil and gave it to the pink flowers because I have some type of prejudice against pink if we're thinking about race. And so you see the difference in terms of what resulted in actually the growth of these flowers. The red flowers kind of thrive, the pink flowers didn't. When you think about this personal mediated racism, it's kind of going back to my preference for red over pink. So, and if we're thinking about color, this could be, you know, two different races. So my preference for one race and not liking another. So I kind of give them kind of, you know, what's left over, and I, you know, give the quality or access to kind of these quality soil and resources is kind of disproportionately, you know, spread out. And then when we think about this internalized racism and kind of how this ties in, kind of imagine, you know, pollen kind of is transported through bees and different things like that. And so imagine that, you know, the bees and the flowers can communicate. And so, you know, over time, you know, bees come and land on the pink flowers, they grab some pollen, they take it to another pink flower. But the other pink flower is like, I don't want pollen from another pink flower that's, you know, substandard. It's not high quality. I want the red flowers pollen because I want to grow and thrive. And so these pink flowers have actually started to internalize that they're not good enough or they're not as good compared to the red flowers, and they actually want to be red. They prefer that because they think, you know, based kind of on the history, this, you know, this growth and these flowers over time, they're like red is better, and they actually start to internalize that. So I thought this was like a really, you know, thinking about everyone kind of knows with flowers and stuff like this, like she did a really good allegory in terms of explaining kind of how racism exists and continues to go on. And we'll kind of talk a little bit more about this as it relates to health disparities as well. So similar to the gardener's tale, institutionalized racism and segregation affects the race of health. And so David Williams is a professor at Harvard. He's done a lot of work. It's kind of really well known in looking at racism and its impact on health disparities, or really sustain and exacerbating health disparities in communities of color. And so you could think about segregation, how it determines socioeconomic status, which then affects the quality of education and potentially employment opportunities. There's a lot of work, which we won't really go into it right now, but a lot of research is kind of like looked into, you know, people don't live in areas that they live in. You don't see that. It's not just by chance. There's a lot of history in terms of, you know, where you could buy land or where you could live and different things like that. And when we look into it from an environmental injustice lens, actually, a lot of the, you know, power plants, a lot of waste sites tend to be located in lower income and communities of color. And we also see the health disparities concentrating in those areas as well, especially when talking about air pollutants. Segregation can create pathogenic neighborhood and housing conditions, or basically poor housing conditions. Kind of another kind of example, thinking about New York, and if you're not as familiar with New York, what I've learned actually, a lot of the housing developments, which are basically government assisted housing, are almost exclusively located around like power plants and waste sites. And actually in the South Bronx, they have one of the highest childhood asthma rates in the country. And some of the research has actually found that, you know, vehicular traffic and kind of like air pollutants, diesel from idling in buses have all basically happens in this area in the South Bronx. And it's been linked to seeing why we actually see these health disparities in that community. Conditions linked to segregation can constrain the practice of health behaviors and encourage unhealthy ones. So what example I like to think of about this is, especially the clinicians, you know, imagine you have a patient who comes into your office and they're pre-diabetic, and you tell them, you know, in order for you not to get diabetes, you should go home and exercise, you know, eat fruits and vegetables, change your diet, different things like that. But imagine this person, you know, is a person of color. Maybe they live in not the greatest neighborhood. They live in a food desert, which kind of by definition is kind of limited access to fresh fruits and vegetables. So, you know, kind of, you know, what you're prescribing a patient is actually not going back in the ideal setting, can make it very difficult for them to kind of adhere to what you want to you know, do in order to improve their health. And then lastly, thinking about segregation and access to medical facilities, and more specifically, quality of care. Kind of going back to the education example, education is considered a right. There's, elementary, middle, high schools located all across the country, but there's not without a doubt that the quality varies, and it's the same with hospitals. It's not always just necessarily from the provider's perspective when you think about the ratio from patient to providers. If I need to go see my primary care provider, but I can't make an appointment for 5 months, that's different quality and becomes problematic compared to I can make an appointment and see my doctor, within a day or two. So next slide. And so kind of going back to Kamara Jones, the first 3 things and thinking about the mechanism relating racism to health, the first few things are kind of reiterated from the previous slide a little bit, thinking about institutional discrimination. I kind of talked about institutional racism and segregation, discrimination. But when we kind of get to the bottom half of the couple points, it really kind of gets down to, I call like the granular level in terms of what we actually see happens, the changes that happen in our bodies when we're exposed to racism, or which a lot of times referred to as psychosocial stress or psychosocial stress related to racism or discrimination. And it actually causes a physiological response. There are biomarkers that could be looked at and assessed. You can kind of look at that relationship as well. But there are multiple theoretical frameworks that basically link racism or this kind of ongoing chronic stress and looking at how it has these negative health consequences, which we see disproportionately among people of color. And so these are just some disparities, some racial disparities that we highlighted. Here, some of these you might be a little bit familiar with. So African Americans have higher death rates compared to whites for the 12 of the 15 leading causes of death. Kind of what Mabel was saying earlier when we're looking at those trends over time. Overall, we've seen the trends, and especially chronic diseases are the leading cause of death in the United States, have declined, but we haven't seen the decline has lagged significantly when we're thinking about comparing African Americans to whites and kind of what we've done. Blacks and American Indians have higher age-specific death rates compared to whites through the retirement years. Ethnic and racial minority groups get sicker sooner, have more severe illnesses, and die sooner compared to whites. And then we're thinking about Hispanics have higher death rates compared to whites for diabetes, hypertension, liver cirrhosis, and homicide. And so these are things kind of like what Mabel was saying. A lot of these disparities, we've been knowing this for a long time, especially on the research side where I sit. A lot of research and a lot of time has been devoted to kind of really trying to identify these disparities. But some of the work efforts and interventions, programs that have been implemented haven't been so effective, when you're looking at the grand scheme of things, because we still have seen these disparities for decades and decades. And so thinking about, if you sit in a research space or thinking about if you're in the health care setting of kind of what could be done kind of going forward. So future research should look into, racism and how it contributes to health disparities. And more specifically, looking at, kind of talked about these biomarkers, how we can look at how chronic stress over time and prolonged exposure to certain chronic stress biomarkers are known to be deleterious to our health. And so kind of looking at that direct relationship from epidemiological studies that are longitudinal, inclusive of ethnic minority groups. Part of the problem actually has been a lot of these kind of longer cohort studies that have been following people over time. There's been a very limited amount of ethnic minority groups included in that. And so what we can kind of infer from these research studies kind of becomes limited because there hasn't been a lot of representation kind of in those research studies. And there's multiple reasons as to why that's the case. But, there is a lot more work needed to be done in the area. And then also something that, thinking about on the practice side, kind of integrating cultural competence and kind of making it the gold standard, or making it, basically required kind of across the United States. The same way that we see like if there's a sexual harassment training annually, there should be kind of this cultural competence training, because, that patient, clinician interaction is important, and that kind of building that rapport will ultimately affect the quality of care that's administered to ethnic minority groups. And most of the, disparities we see in terms of, especially chronic illnesses, are almost exclusively or negatively impact ethnic minority groups. So kind of having this cultural competition kind of built into practice becomes a key player in terms of trying to address and eliminate these disparities that we've been sharing today. So now I'm actually turn it over to Attila. She's going to talk a little bit more about some of the theoretical frameworks linking racism to health outcomes.
Okay, so we're going to get a little abstract, a little deep in our understanding of racism in health now. It's been great that we've had such great efforts in epidemiological studies looking at the differences and disparities of health between racial categories, but that's not necessarily the study of racism in health. It's important to really acknowledge the mechanisms through which racism is displayed and understanding how that affects health. And so in that process, we've had public health scholars who have developed frameworks that really have bridged off of the theories of critical race theory and looking at racism and its effects on public health, specifically adverse health outcomes. So within that development of theories, Dr. Chandra Ford, who is the director of the Center of Racism, Social Justice, and Health at UCLA, has developed with her colleagues what's called the Public Health Critical Race Practice. And so what this praxis and this model or methodology is just that. It's a scientific methodology that incorporates theory as well as methodological rigor to understand and help ultimately researchers through the process of conducting race-conscious research that really gets to the root stems of health inequities. So not necessarily just looking at differences in health among racial groups, but really looking at those root causes of racism and taking a race-conscious lens. Next slide. So looking at the public health critical race praxis model, we have various concepts. And so the concepts employed in this model consist of 4 focuses and 10 basic principles. So for the sake of time, I'm not going to go over the 10 principles, but I do want to shed light on the 4 focuses of the model. And in understanding the focuses, it's important that we look at the overarching theme of racial consciousness. So we want to take an orientation that brings awareness of the ways that racialization as well as racial dynamics within our society are affecting the way we approach racism in health research, as well as the way individuals experience racism and its effects on health. So it's important to have that racial conscious lens and understanding these 4 focuses. So when we look at the focuses, the first focus, and this is a semi-structured model, so there's no linear process in this model. It's very much a free-flowing model, and you can take and choose what you want to address your research interests of focus. So we look at contemporary patterns of racial relations. So in understanding, if you're studying racism in health, it's important to understand that in looking at racism, we want to look at the contemporary patterns of racism. So we're not looking at the 1950s Jim Crow's forms of racism, those overt forms of racism necessarily. We should focus on contemporary forms such as covert forms of racism, microaggressions, school to prison pipeline, looking at things like police brutality or just the trauma, a lot of historical trauma from racism, things like that. So in developing your research topic, it's important to make sure you're characterizing racism appropriately for the context in which you're studying, the current context. So you want to ask yourself, what mechanisms does racism work? We're not looking at the mechanism, we're looking at mechanisms such as residential segregation, mechanisms like police brutality, trauma, things of that such. So getting clear on the social context and the times and those specific racial patterns of interest. The second focus is knowledge production. So, and understanding the previous literature as it relates to racism and health, or even just health disparities among racial categories, you need to understand the influence of potential racialization or racial beliefs about groups, and understanding how that may have previously affected the knowledge production of your specific area. So you want to challenge those forms of possible racialization and biases, and really just have an understanding that maybe we may need to change the narrative of what we're studying or how we're studying it. Maybe as opposed to looking at a specific racial group as one of deficits, you might want to look at the racial group as one that is resilient, and changing the narrative in the way which we're studying the group. So understanding the biases that may be present in previous knowledge production of your specific topic of interest, as well as the ways in which you may also be biased in your research design, as well as your studying of the population. Next, we look at conceptualization and measurement. And so I'll actually go into a little bit deeper about these next two focuses: conceptualization and measurement and action. So I think what deters people from studying racism and health is the abstract idea of racism. How do we study racism? How do we measure racism? How do we operationalize racism? And I think it's important for researchers to take that understanding when developing their research design. How are you going to be studying these racism-related constructs? And how are you going to hypothesize relationships between these constructs, these social contexts, as well as its effects on health outcomes? So it's important that we look at measurement and understand that there's various ways of studying racism. So if we're studying something, which I'll discuss in the next slide, such as residential segregation, are we looking at measurements or proxies of residential segregation, such as zip codes, clustering, things like that? And then we have the last focus, which is action. So in the word or the term Praxis, it's important that we're not just collecting data for the sake of collecting data, right? It's important that we take this data and turn it into action within the communities. It's a common practice, specifically people or researchers not of color, to go in communities, take data, and not give anything back. Really just not putting back anything into the community. So it's important that we take action, whether that's legal action, whether that's changing of policies, which we'll discuss a little bit more, but we need to take the knowledge that we're getting and the evidence and data and create action. Next slide. So here's an example of the way the public health critical race praxis can be used. So this is really looking not even just a cross-section or longitudinal study, but this is more so a literature review. And so the author was looking at literature as it relates to endometrial cancer among populations, Black women populations. So if you look at phase 1, contemporary patterns of racial relations, you see it's important to place endometrial cancer disparities data in the context of current societal racial stratification. So understanding the racial stratification and the current context, understanding what that racial stratification looks like among African-American women as it relates to endometrial cancer disparities. Looking at phase 2, knowledge production, we want to apply a critical lens to current body of research, really looking at the current body of research about endometrial cancer and providing a race-conscious critical lens. Are there racial biases in the way that we're presenting the data about these women? And if so, maybe we want to focus the perspective on Black women, not necessarily looking at this group as a deficit, but looking at them as a group of resiliency and looking at the resources potentially present within this group as it relates to endometrial cancer. So really changing the narrative of the knowledge, as well as identifying gaps. And then we have the conceptualization and measurement of endometrial cancer among Black women. So we want to fill the gaps with study designs that incorporate complexity of race, history, and gender. And so when we look at those different categories, the term intersectionality comes to mind, right? We want to understand that Black women particularly are a complex group in that they have identities in various categories. And these different identities are usually ones of identities that are oppressed. So understanding the differences in the oppression based on their membership in these different identities and understanding how that influences endometrial cancer diagnosis, treatment, screening, etc. So really looking at the conceptualization and measurement a little bit differently, taking in those concepts of intersectionality and really just studying race and racism a little bit different. And then action, of course. We want to act on modifiable influences of inequity with engagement of both communities of Black women, providers, and healthcare systems. So I can't highlight enough the importance of engaging the community. Oftentimes, we as researchers just take, like I said before, we just take the information and then the community members never hear from us again. And so even with my own work or my future work, I hope to incorporate concepts such as community-based participatory research. So involving the community from the beginning of the research till the end. So involving them in the development of the research topic, the research question, the research design, data collection, providing the community with skills that they can then use once I'm gone and I've collected the data to enhance and improve their skills. So it's important to take action, not necessarily just taking the information, but providing something for the community, as well as action that can then be influenced among providers and healthcare systems. So it's not necessarily just focusing on providers, but we want to change systems, right? We understand that racism is not just an individual, doesn't just have individual effects, but we need to get to those levels of policies and systems, right? Changing the systems. So next slide. Again, so wanting to focus on the measurement of racism, I think public health providers think they're doing racism research when they discuss disparities among racial categories. That's not racism research. So we need to get past more than merely identifying differences in health outcomes among racial groups. We've done that. We know that African Americans have, adverse outcomes compared to their white counterparts. What we really need to focus on is understanding the mechanisms of racism and how those mechanisms perpetuate the health differences and the health inequities. So some examples of racism in health research that are starting to trend is really looking at racial segregation and adverse birth outcomes. So understanding those things like zip codes, clustering, so looking at the density of a community as it relates to a minority group in relation to a majority group. So of people of color versus non-people of color, so the majority population. Understanding how that clustering and that centering and that racial stratification or composition of that community may be a link to adverse birth outcomes, right? So when we talk about racial segregation, it's important that we get clear on how we're measuring or operationalizing it, right? So what does racial segregation look like in a research study? How are we measuring racial segregation? So looking at those different proxies and ways we can measure racial segregation. And then again, things like microaggressions, keeping in mind, understanding the contemporary forms of racism. We're not talking about overt forms of racism like physical harm and things like that we may have seen in the 1950s with Jim Crows and things like that. We're talking about current contemporary forms of racism. So those everyday feelings of, stress and those microaggressions and how it affects things like adverse cardiovascular outcomes. So looking at things like hypertension, cortisol levels, things of that such. Next slide. Again, the most important part, I believe, is in bringing this whole critical race full circle is taking action. It's important to have praxis, right? Without the action, what is the point of all of the data we've developed? So in terms of taking action, there's a lot of ways action can take place. So policy reform. I always say that my goal after I get this dissertation is to develop and conduct research that influences policy, right? We have to make those policy changes to influence structures and systems. Centering the margins, so changing the narrative about Black women or about minorities, populations of color as it relates to health outcomes. So typically those who are writing these articles are people who are not of communities of color. So we want to change the narrative and take those minority narratives and make those the center and base our research off of their narratives. And then of course, community involvement, doing community-based participatory research is important and a great way of involving the community. And then if you see throughout your research that, you know, there's an opportunity for direct legal action, that's always great. I'm always take them to court, all right? Make some real changes there. So next slide. So with all that being said, I think it's important that we provide you all with a list of resources where you can further your understanding of racism in health, as well as health disparities among racial categories. So I've provided a website. Specifically, you can look at UCLA's Center for the Study of Racism, Social Justice, and Health. You can just Google that. It'll take you right to Dr. Chandra Ford's center, and there they have information on other scholars who are studying racism in health, as well as social justice, opportunities for you to attend talks or other webinars. And I believe Jamie posted something on Harvard University. You want to talk about that a little bit?
Yeah, I just posted, I mentioned some of the, when I brought up David Williams kind of in our talk of kind of being one of the researchers that kind of focus a lot about, have historically talked a lot about racism and its impact on health outcomes. Or it's a TED talk that he gave that I think is pretty interesting. That kind of talks about that if you're interested in looking at that. And then also there was just this report that was put out last year, this annual review of public health. And it kind of basically, you know, kind of gives you this background of kind of these issues that are going on and kind of thinking about the future, you know, in terms of research and kind of looking at racism, kind of like what we talked about today. So that might be of interest, especially for anyone who's involved in research.
And then also I've listed a resource as it relates to literature. So Dr. Chandra Ford, as well as other colleagues, have developed a book called Racism, Science, and Tools for the Public Health Professional. And it really details the workings of studying racism in health, and specifically that mechanism, the various mechanisms of racism, and understanding these key terms and what that means for public health professionals, public health researchers. And I was able to contribute to that book, and it was just presented at the last American Public Health Association conference. So if you have, you know, the money, or you just want further information about racism in health, that would be a great source and guide for you. Sands, you got to unmute yourself. There you go.
Okay, so this is the part where you can ask us questions, and we'll do our best to answer your questions. So let us know if there's anything that you that came up for you while we were doing the presentation. Anyone? Let's see.
Oh, I see a question. It says, Have you guys heard of Dr. Nadine Burke Harris, Surgeon General, right? First African American Surgeon General.
Oh, yeah.
Yeah, who does childhood adversity studies in her health clinic in San Francisco, Hunters Point. You, yeah. I am aware of her, not necessarily fully aware of her research, but I know she has made great strides if she made it to become the Surgeon General. So.
Any other questions? Ashley, Janae, Benita, and Tiffany?
Oh, okay. This is a good question. So if you're not in the health field, then what can you do besides have awareness of these issues?
Talk about it, discuss it, address the elephant in the room, because usually there's a lot of stigma and it's not, people don't want to talk about racism. It's like I said, based on the webinar that we did today, it's a hard conversation to have, but necessary. So bringing it up, in a professional way, I would say, just, poking everyone's or whoever you're around, or maybe your colleagues, your friends, about, asking like, hey, do you have any ideas about disparities? And is it something that you've heard of? In terms of the lack of access to resources in communities of color. That sometimes you'll be surprised how some people haven't really heard of this, even though it's been going on for a really long time. We have more questions.
No, I was gonna also say, I think like what Mabel was saying, the kind of awareness part, but like, as an individual or, people who might be affected in this way, a lot of literature is really kind of pointed to not only that do these things exist, but there's a disproportionate level of access when we're thinking about mental health and kind of how we're coping with stress and racism. And so it's kind of important for you kind of as an individual to learn which coping mechanisms, healthy coping mechanisms work well for you, because, ultimately we don't want to have you basically continue to get the short end of the stick. Because again, some of these things, like you talked about, microaggressions or things like that, that people start to internalize, and they don't necessarily cope with it appropriately. And it kind of basically we see these differences in, cardiovascular disease and different things like that.
I would also say from a clinical standpoint, advocate for yourself when you're going to, these healthcare appointments, or when you have a loved one in the hospital. If something doesn't feel right, speak up. We know we've seen the viral story of Serena Williams and the racism that occurred during her pregnancy and her childbirth, and her ability to advocate for herself was a way in which she combated the racism that she was experiencing. Although she's a celebrity and someone who's in the limelight, she also experienced a form of racism when providers weren't really being attentive to her needs and her concerns of what was going on with her body. So not just understanding racism, but when you're in these healthcare settings, advocate for yourself. When I work at Cedars-Sinai, so I work in a population where it's not one that's underserved. I get a lot of celebrities, I get a lot of CEOs, people with access to money. But when I get those people who may have been transferred for a higher level of care, I inform them that it's their right to advocate for their health, right? So let the doctors know if you have questions, making sure you have the knowledge before you even go to a healthcare provider appointment, right? So beating them before they beat you, being well aware and understanding your rights as a patient.
Okay, thank you. We have 3 more questions from Benita. It says, regarding the public health critical race theory, have you all utilized this in your current research?
It's a very abstract theory. I mean, I've seen it's still a fairly new like framework and model. I've seen it used in like HIV work, as well as police brutality, or understanding police brutality and health outcomes. I believe that like that was done with also David Williams using this model in police brutality and adverse health outcomes. For me, currently, I haven't used it for my research. I'm doing a secondary data analysis, so I'm not necessarily looking at theoretical models at this moment, more so statistical models. So I think it is a gem because you can pick and choose pieces from it that, you know, can help direct your research, or even if you don't want to do racism in health research, just keeps you aware of the racialization that may be present among the population you're studying, or among the health outcome you're interested in looking at. So it is a complex model, but it is gaining attention, I believe, in the public health field.
Yeah, and it sounds like, am I on? And it sounds like it's something that's, that's more detailed in terms of like different variables that it's looking at. So it's obviously something that's more helpful, especially because, like Atala said earlier, we've known for a while that these disparities exist. But like, what are they specifically, and how can we understand and get more detail in terms of the root causes of those disparities that cause the trends that's been happening for decades and decades, but we haven't been able to close the gap. So the critical race theory sounds like it's something that's useful in terms of helping and assisting in trying to close those gaps, because now we can understand what the root causes are. As a medical student, for me, being aware of these kind of issues is really important, because I'll be seeing patients and things like that. I've had my experiences as a researcher, but at that time I didn't use that specific framework. But in the future, once I finish medical school, as a future, also a public health practitioner and a physician, this is definitely something I'm going to, take into consideration in terms of assisting in eliminating health disparities that we see and exist in the minority communities. So there's another question from Benita. It says, applying the race and public health research into practice, what would be your recommendation or thoughts for grants writers regarding the language used? Good one.
Yeah, I think it depends. Well, so usually there's a call for a grant, and it kind of depends on, I guess, if you're getting a grant from a foundation versus, we're talking about the National Institutes of Health type of grant. From what I've seen, foundational grants usually are like specific. Someone has some type of philanthropy that they're interested in, giving money to do research on this very, like if it's looking at, reducing recidivism among African-American males, it's like very, very specific. So, if you kind of just follow the framework of kind of how a grant will be written, you don't have to, that would kind of be woven into that. On the government side, I know it's usually grants, sometimes depending on the mechanism, that could be very broad, but they usually focus on a particular, especially thinking about disparities on a particular race. You will have to integrate, whether it's critical race theory or some other type of theoretical framework, to kind of explain what you're proposing and how your research study will either capture that, or if it's an intervention, how it's going to affect, somehow change or reduce, disparities in outcomes or something like that. But I would just kind of summing it up is basically, it kind of probably depends on where the call for the grant is. But it'll usually probably have some type of racial component in the actual call for the grant itself.
Yeah, I mean, I think a recommendation for grant writers regarding the language use, I mean, it really depends on it depends on like what's like your experience, you know, like if you're new to public health, obviously like you have to take consideration the fact that you're learning, and like public health to me, at least in my opinion, is a language. You know, you have to learn this new language and try to apply it into your practice. So if you're a new person writing grants, you have to, you know, be kind to yourself in terms of you know, getting to a point where you understand the language that are used deeply so that you can share and advocate for the issues that you're trying to write a grant for. But the more that you talk about it, the more that you know, write small grants here and there, the more practice you'll get so that you'll be able to essentially you know, be able to have these the conversation, or be able to write so that you're able to convey the right things that you're trying to address in the grant. I hope that that answered your question. But I think in the beginning of the presentation, what we did was we added some of the terms that are usually used in the public health world. I mean, for me, I know specifically that, you know, when I started to learn about public health in undergrad and graduate school and all these things, it wasn't, you know, it wasn't something that was easy or right away. So you have to give yourself time to be able to wrap your head around understanding how to use the language in public health. Okay, so last question from Tiffany. It says, does special education and how it impacts children of color fit in your studies of public health in communities of color?
I'm sorry, repeat the question one more time. I'm sorry.
Does special education and how it impacts children of color fit into your studies of public health in communities of color?
For me, not necessarily so, just because I'm not studying children and special education. I could see maybe, I don't know, understanding the trauma in being a child of color in a special education program, like understanding the trauma inflicted from that may be interesting, and understanding maybe prep adherence. I'm just trying to link it together if I had participants who had that experience. So for me, I'd have to know if they've had that experience to really understand how it relates with my topics. But I think it's an important research. For me, no, I haven't really delved into that area. That's not really my focus, but it is important in understanding possibly trauma related to special education. And I think more so understanding the hyper, I guess, the school system's hyper vigilance and really shuffling like boys of color into special education, and what that may look like in terms of like the school to prison pipeline. I think that would be interesting research, because from my understanding, I don't have statistics on this, I feel like there's a higher rate of African-American boys in special education, as well as those behavioral, you know, courses, IEPs, things like that, and understanding that as a form of racism, like institutional racism, and its effects on health outcomes would be interesting.
Yeah. Go ahead, Jamie.
No, I was gonna say, it doesn't fit directly in the research that I do, but I know it does exist. I guess they're actually coincidentally, I'm working on this analysis right now with a colleague at school, who she specifically looks more from a psychology. She's just a statistician, but it's a study, a cohort study has been going on since the 90s. And it really was following children in school and kind of looking at antisocial behavior and looking at all these different other factors, like, you know, income, you know, source of income, different housing, you know, whether some people were homeless or not, the parents, job and all these different things. So I don't think special education hasn't come up like specifically in that analysis, but there is a lot of overlap. Especially when you're looking at psychology and public health or mental health, and different outcomes with education. There's a lot of overlap that happens with that.
Okay. I mean, for my experience, special education and how it impacts children of color, it's not something that I specifically looked at. I was more so in infectious diseases, but I have colleagues that do look at this issue specifically, and hopefully in the future that's something that we can have a discussion about. And then there's one last question. It says clarification, and you don't have to talk more about it due to time, but my apologies if I was not clear. Oftentimes when describing the population in grants, it is demeaning or degrading in order to convey the need. My question is, what are your thoughts on how the language can be changed as it relates to describing population we research? That's a good question. That was very specific. Any thoughts?
I mean, there is kind of like, I think when you're talking about different groups, especially we're talking about marginalized groups and different things like that, there are some standard languages that are supposed to be used, some of which I've actually learned as a student. I mean, one example, this isn't with race, but like, you're talking about saying, a person with a disability versus a person with a disability versus disabled person, or slight nuances, kind of how you refer to people. I think it's just kind of having a understanding that kind of what should be used in that way. But yeah, there's supposed to be standard language that's used. But if that's what's submitted all the time, I doubt it, because everyone doesn't get the grant, but yeah.
I think the first thing that really comes to mind for me when you ask about like how you can change the language when you're trying to communicate something about a population. There's some, I think the first thing that comes is like, instead of saying like, sexually transmitted disease, sexually transmitted infections, or instead of saying retarded, saying, there's another word that's used that you can use to like address certain populations. And it's really just gonna depend on like, and this is something that my mentor told me too. It's like when you're doing a specific research, like you have to think of yourself as like the expert in that. And so it's really going to come down to like yourself researching some of the language that's being used currently in that specific population that you're looking at, and seeing what other people have used to kind of change the words that that you're trying to communicate. I hope that makes sense. So it's like I said, it's just most likely we're going to end up in just figuring out and researching what other people have done and the best practices around the grant that you're trying to write.
I think for my research, I've seen, I guess, just a pattern of the language around homosexuality, gay, bisexual, specifically among African-American men, and we're starting to use the term just MSN, men who have sex with men. Not only is it not such a triggering, term, it also is all-encompassing. So I have been seeing changes in how we, the verbiage for specific populations. Yes, there still are research researchers that get grants based on work done with gay and bisexual, quote unquote, population, but I have been seeing a trend in using more, I don't know, politically correct and less triggering terms like MSM. And not only that, it's an overarching term, so it encapsulates many different subpopulations.
All right, everyone. If you have any last questions, share now. And if not, we thank you for making the time to be here again. We hope that you continue to follow our pages on Instagram or Facebook or LinkedIn and stay connected, and continue to look out for other things that we do in the future. This was a great conversation, and we hope that you learned something that you'll be able to share with someone in your, in your work community or family or friends and things of that sort. Any last comments, Attila and Jamie?
It was a pleasure. I hope it inspired you all to take, a deeper look into racism in health and understand I can't, reiterate it enough. Like when we're talking about racism, we're not just talking about differences in health among racial categories. We're talking about the mechanisms of racism and how those affect those differences in health. So if that's one takeaway you can get from this webinar, from me at least, understand the difference between racial health disparities and racism in health. Although those are important in order to, address those inequities and inequalities, we got to understand what's going on with the racism. That's my takeaway, but it was a pleasure.
Any last minute?
Yeah. No, I was just going to thank everyone for coming, and kind of walking through this with us. It is a very important topic. I think for all three of us, it holds a special place with us individually. And our work in some way or another is kind of overlapping, looking at this. So again, thank you for coming. Hopefully this continues to be a conversation, both in professional and personal settings as well.
Everyone, thank you, and we'll be posting this video on the website. Take care. Have an amazing evening.
Bye.
Bye.
Thank you.